Hello, everyone. My name is Shreyas Joshi, and I'm going to be sharing with you the presentation I made about the topic that I chose for this semester, which is, as you can see, smoking behavior in the cancer patient. And this is regarding patients that have already been diagnosed with cancer or who have survived a cancer diagnosis after treatment and who continue to smoke. And I think that it's an interesting public health demographic that has a lot to do with the behavioral aspect of these users. And so I wanted to delve a little bit deeper into what theories could be involved and how we can potentially intervene. So, why is smoking in the cancer patient important? Well, as we all know, smoking and the use of other tobacco products has a well-established causative association with many primary cancers. I've listed a few here: lung, bladder, kidney, the GI tract, head and neck, among many others. Smoking can directly affect the effectiveness of cancer therapy and treatment outcomes. Hence, patients who have been diagnosed with one of these primary malignancies and are actively getting treatment can not fare as well as those as their peers who are not smoking. Smoking is also responsible for a significant proportion of secondary malignancies in this population, which is always a big problem when clinicians are dealing with these patients in the long term, especially if they survive their first malignancy. And many studies have demonstrated that all in all, they have higher mortality rates in survivors who continue to smoke versus those who abstain. So, looking at the prevalence of smokers in the cancer population, it's a little bit difficult because there are so many different cancers and so many different uh, articles and journals out there looking at specific subpopulations of, because they are all specialists in their own malignancy. And combining them all has been a little bit difficult. That being said, all the studies kind of revolve around the same numbers and come to the same conclusions that survey-based studies, they suggest less than half, in one of the ones that I'm highlighting here, 44% of smoking cancer patients quit smoking after a diagnosis, so less than half. And what probably is a little bit more troubling is that less than two-thirds of these cancer patients said that they were actually counseled about tobacco cessation by their physicians. Um, the smoking costs in the United States continue to grow annually. These are 2014 numbers. There was 300 billion in healthcare costs related to smoking-related illness, and 170 billion directly in medical care for adults. 156 billion in lost productivity, and 5.6 billion of which was due to secondhand smoke. About a third of all this medical care goes to cancer-related care from smoking. Uh, what I've underlined here is that there are no large population-based estimates, as I mentioned, of smoking prevalence and costs, and that is a little bit of a deficiency in our current data, but is something that we can certainly work on. And lastly, cancer patients are particularly at high risk for smoking-related illnesses. For several reasons. I've just highlighted a few here. A, they have weakened immune systems. Their smoking itself interferes with wound healing after procedures or surgeries and can directly affect the response to chemotherapy or radiation. And lastly, these patients have already demonstrated a genetic susceptibility, if you will, to uh, neoplasms because of either their other environmental factors or because of smoking. And adding to this milieu with continued smoke exposure is only going to make their genetic susceptibility more pronounced. So the theories used in the two studies that I've kind of highlighted here were the first one was a trans-theoretical model. As you all know, the trans-theoretical model of change defines 5 stages of behavior as pre-contemplation, contemplation, planning, action, and maintenance. And the study designers and authors here use the trans-theoretical model as a means to help physicians understand the behavioral theory underpinnings of smoking behavior. Uh, Basically, what they were trying to do is attempt to get more physicians who really are not trained in behavioral theories to more effectively provide smoking cessation counseling at the point of care. What they did was they created a system that was a little bit more nuanced in a questionnaire that they can give patients before an appointment or, say, in a waiting room that can help clinician identify the stage of behavioral change that the patient is in so that they can tailor the message as appropriate. This is a sample that I took from their paper, and I think it's a very good illustration of the trans-theoretical model in use. This is something a patient would answer in a questionnaire, this first box up here. in, say, the waiting room. And if they answered 1, 2, or 3, meaning that they smoke currently, then we start to go down the flow chart here to try and figure out whether they're in the pre-contemplation stage up to the preparation stage. They even include, a stage here of patients who have never smoked, and so they don't need any counseling. I think this is a very useful way for a clinician who's not necessarily trained in behavioral constructs to understand where a patient is at and to intervene based on their actual stage. So, of course, I think this has very good strengths. I think the trans-theoretical model has been effectively used in many prior smoking cessation programs for many subpopulations. It's effective, and it effectively and simply explains the stages of behavioral change to clinicians not familiar with behavioral theories, and it allows for quick personalization of smoking cessation messaging based on the stage of behavioral change, just quickly from that flowchart as we saw. Of course, it has some weaknesses. One of the major problems with this is that clinicians would need to learn many different messages, which is kind of a barrier to actual utilization, based on which stage their patient is in, and to understand how to frame that messaging so that it actually sinks in with their cancer patient. And this theory also doesn't directly address any cognitive behavioral attributes that are known to be very important in smoking cessation, which is why I picked another article that used more behavioral cognitive constructs in order to try and explain how cancer patients continue smoking, how or why. So in this one paper I utilized, they used 2 different constructs, behavioral cognitive constructs. One was behavior-specific self-blame, and the second was perceived control over their future outcomes. Now, this was a study of head and neck cancer patients. Why? Because head and neck cancer is one of the few that is very strongly correlated with smoking or tobacco products such as chewing tobacco. That we know directly causes the primary malignancies and can cause continued malignant activity after treatment. Previous evidence suggested that about 35% of patients or more continue to smoke following surgery or radiation, and in this population, treatment is actually quite radical. And I would think smoking through a tracheostomy. So continued behavior of this kind in this patient population is quite extreme in some cases. And this is one figure that I highlighted from the paper that I think explains it well. I'm going to focus on the curve with the open circles that have patients with high behavioral self-blame, meaning they know that their previous activity and smoking habit has likely led to their malignancy. And those, unfortunately, with low perceived control have a much higher likelihood of continued smoking than those with higher perceived control, which right away points to a potential intervention point. Taking patients who have a high behavioral self-blame and who have low perceived control, if we can somehow manage to improve their self-efficacy and their perceived control, we can drop their likelihood of quitting by almost 3 times. So I think behavioral cognition in the social cognitive theory has a variety of strengths. It's clear, it's explained, there's a clear and explainable link between smoking and cancer diagnosis or prognosis, in layman's term, for a patient or health. And I think that cognitively they can understand that quite easily. It's also important, to utilize this, I think, because many previous smoking cessation studies have already identified perceived control as an important construct, and so it does have a factual underpinning that has previously been studied. There are, of course, several weaknesses to using just these constructs alone. And one of them is that sometimes measuring them is a little bit difficult. The authors of this paper talked about appropriately measuring self-blame, and because there are different versions of self-blame that have different adaptational correlates, it gets a little bit tricky. And secondly, perceived control and self-blame could be related to depression. And though this could be controlled for in prospective studies, it's actually very hard to do in observational retrospective studies that may not have looked for depression very specifically. And in this specific paper, they actually tried to do it retrospectively, but didn't have an adequate sampling to comment on the correlation or confounding. So I think that this, would need to be addressed along with other confounders in any future studies. So this is the conceptual model that I put together, trying to kind of bridge the gap between the two theories I just discussed, the trans-theoretical model and the social cognitive theory. I'm going to walk you through it real quick, which hopefully it's quite straightforward. A patient is diagnosed with a cancer, and they have cognitive beliefs about that cancer. They have a certain amount of cancer-related distress. How bad is their cancer? How much, are they actually physically and mentally suffering? Next, there's a correlational perception, meaning do they think that their actual activity or their habit has led to the cancer or to their current state of health? And lastly, and related, is the self-blame. Not only do they think about whether or not their personal habit has led to their cancer, but how guilty or self-conscious do they feel about that? The correlational perception and the self-blame then feed into the perceived behavioral control over their future cancer outcomes or their future health. That, along with the cancer-related distress, will inform a clinician about the stage of their behavior change. And this is taken directly from the trans-theoretical model. I didn't break it down into the 5 different stages because I think we all know that. But based on their stage of behavioral change, we can inform our interventions or cues to action to actually get smoking cessation, which is the end product that we're looking to achieve. So I just kind of highlighted here the two theories that I tried to blend together here. This is part of the social cognitive aspect, mostly the personal cognitive aspects of the theory, combined with what we see here, which is more of the trans-theoretical model and these cues to action, which is these are important in several of the theories and bridge several of the theories. And ultimately, we get smoking cessation, hopefully, if we can purposefully intervene upon this axis. I'm going to be specifically looking at what's in this red oval here, which is how can we impact behavioral control or self-efficacy in these patients, and how can we potentially change the stage of behavior that they're in within the trans-theoretical model in order to move them into the action stage and eventually, hopefully, into the maintenance stage. So in conclusion, the application of a conceptual model combining elements of a cognitive theory and the trans-theoretical model can, I think, offer a way to study and measure smoking behaviors in cancer patients and provide insight into how to tailor interventions and messages based on individual cognitive and behavioral states. Moving forward, I'm going to be thinking about the constructs in this red oval and how we can apply that to an intervention program. These are my references, and thank you very much for your attention.